starting the poster presentation, I hand over to the Dr. Venkatesh sir. It is 3 minutes for the presentation and 2 minutes for the discussion.
I request now Dr. Deepthi to start poster presentation.
Good evening, everyone here. I'll be presenting a poster on multiple ileal perforation in intestinal TB, a case report. Coming to the introduction, ileal perforation is the most common site of intestinal perforation in abdominal TB. It is believed to be an uncommon complication of abdominal tuberculosis with incidence of 1:15%. 90% of the tubercular perforations are solitary and occur in distal 1 meter of the ileum. Perforation is a life-threatening complication of intestinal TB with high morbidity and mortality. Case scenario, a 50-year-old post-ileostomy patient presented with progressively worsening abdominal pain and obstipation since 5 days. On examination, he was cachectic, hypotensive, and tachycardic with previous midline laparotomy scar, distended, diffusely tender and rigid abdomen with sluggish bowel sounds. He was a known case of chronic pancreatitis with type 2 diabetes mellitus. He had underwent ileostomy for intestinal obstruction 2 years back and splenic abscess drainage 2 weeks back subcutaneously. HB count was 10.5, WBC count was raised, ESR was raised, RFT and LFT was deranged, HIV was negative, chest X-ray showed bilateral upper lobe haziness, CT abdomen and pelvis showed 1.5 to 2 liter free fluid in the abdominal cavity and interbowel loop, query secondary to hollow viscous perforation. Patient underwent emergency exploratory laparotomy and the following were noted intraoperatively. 2 liter of the pus or fluid drained from the abdominal cavity, multiple perforations noted in the ileum proximal to the ileostomy, multiple necrotic patches on the bowel were noted, and the involved segment of the bowel was resected and ileostomy revision was done. This is the perforated ileum, and also note the multiple perforations at the areas of necrotic patches in the bowel. This is the resected bowel segment and acid bacilli was seen. CBNAT showed positive for mycobacteria. HP of the resected bowel segment showed multiple focal denudation of lining epithelium with of congested blood vessels, evidence of hemorrhage, necrosis, and edema, multiple taking granulomas in the small intestine. Unfortunately, due to multi-organ dysfunction, we lost the patient 48 hours after surgery. Coming to the discussion, abdominal tuberculosis is the second and the sixth most common site of tuberculosis in developing and developed countries, respectively. The most common site of intestinal perforation is the terminal ileum because of high absorptive rate, close contact of the bacilli with the mucosa, presence of abundant lymphoid tissues, and being a region of physiological stasis. Complications such as obstruction, perforation, bleeding, and fistula formation leads to hospitalization and involvement of surgeons in their care. Surgical management of tubercular perforation should be individualized. Coming to the conclusion, often solitary perforations are encountered in intestinal TB. Hence, it is necessary to make the surgical community aware of such an atypical manifestation of intestinal TB so as to be more prepared if such a case is encountered. These are my references. Thank you.
I welcome Dr. Rajshekhar sir to proceed with the judging. Dr. Rajshekhar from Chiraga.
Yeah.
So please mute your speakers except Rajshekhar sir.
Yeah. Patient had ileostomy before. Hello, can you hear me?
Yes, sir. Yeah, please, sir. Please ask, sir.
Before it was diagnosed as ileal perforation or peritonitis. Actually, patient must have come with peritonitis. So patient had an ileostomy for what?
Sir, the evidence was not available with us, sir. It was done 2 years back. The reports or evidence of why it was done was not available with us. It was done in an outside hospital.
Can you please repeat it?
Sir, the evidence of the previous operations was not available with the patient.
Okay. So ileal, okay, post surgery after resection, what did you do? You did again jejunostomy or ileostomy, or you have connected it again to the colon?
Sir, we did revision ileostomy, sir.
You did ileostomy.
resected the bowel and we did revision ileostomy.
And the abdomen was drained.
So the
Retinal
pus,
cavity was drained.
there was pus, sir. We drained that and resection of the bowel. It was necrosis. Bowel, part of the bowel was necrosis. So we resected the bowel segment and we did ileostomy revision, sir.
Okay, ileostomy. Fine.
Yeah,
What
any other-
cause of the mortality? Why did the patient succumb
Sir,
in spite of the treatment?
Sir, he actually presented very late to us, sir. So he was already in septic shock and his RFT and LFT was deranged. He was in multi-organ failure, sir. So couldn't do much.
How many days he survived post surgery?
Sir, 48 hours after surgery, he was there, sir.
He was in ICU.
So I didn't get you, sir.
Was he in ICU that
Yes,
time?
yes, sir. ICU, sir.
Okay.
Did you
Right.
consider the possibility of adrenal failure in this patient?
Sir, if
Because you can get kind of Waterhouse Fredrickson kind of picture in miliary tuberculosis,
yes,
extensive tuberculosis, and giving steroids in such patients. I agree that he is in multi-organ failure, but did you consider giving steroid supplementation to possibly overcome the adrenal failure?
sir, initially was just to stabilize the patient, sir.
No,
Later,
I agree. I
plan of-
agree with all of that. I'm not questioning what you have done,
Yes,
but it is important for all the students to understand that adrenal failure is one of the salient things that happen when there is extensive tuberculosis like this.
yes, sir. You could have considered it, sir.
Yeah.
Yes, sir. Thank you, sir. We'll move on to the next paper. Thank you, doctor.
Thank you, sir.
Next paper, yes.
This was Dr. Deepthi, no?
Yeah, meanwhile, I welcome Dr. Siddesh. Siddesh, sir. President-elect, ASI.
Hello. Hello. Hello, sir.
Hello, sir.
Okay, Dr. Siddesh.
Thank you, sir.
You can.
Good evening, everyone. Here is a rare presentation of eosinophilic gastroenteritis. Introduction. Eosinophilic gastroenteritis is a rare disorder characterized by eosinophilic infiltration of the bowel wall with various gastrointestinal manifestation, wherein gastrointestinal perforation is a rare presentation. The estimated prevalence of eosinophilic gastroenteritis is 8.4 per 100,000 population. Here, we present a case of dual synchronous perforation of ileum and vermiform appendix secondary to eosinophilic enteritis, a combination making this case quite unique. A 55-year-old male presented with chief complaint of colicky lower abdomen pain since last 3 days, which was aggravated in the last 3 hours. There was no history of vomiting, fever, altered bowel habits, allergy to food or milk products, or any other previous surgery in the past. On examination, vital signs were normal, and per abdomen, at the time of admission, rigidity was present over the right iliac fossa with diffuse tenderness, which gradually progressed to diffuse rigidity all over the abdomen. Pararectal findings are normal. A clinical provisional diagnosis of acute appendicitis with query perforation was made. Investigations. Blood investigations showed total counts of 9,900, neutrophils of 90%, eosinophils of 1%. Peripheral blood smear showed normocytic normochromic with neutrophilia. X-ray erect abdomen was within normal limit. USG abdomen and pelvis showed probe tenderness in the right iliac fossa. Appendix could not be identified. CECT abdomen and pelvis showed dilated appendix with appendicolith and periappendical fat stranding, and the adjacent bowel wall was thickened. Patient was taken up for open appendectomy using McBurney's incision. Fecal contaminated fluid was noted in the peritoneal cavity. Appendix was inflamed, perforated with appendicolith, and appendectomy was performed. A second lower midline incision was made in suspicion of any dual pathology. Ileal perforation was noted 50 centimeters proximal to ileocecal junction. 20 centimeters of ileal segment surrounding the perforation was congested and cicatrized. Ileal resection was done along with double barrel ileostomy. The histopathology report of ileal and appendectomy specimen showed eosinophilic enteritis, wherein eosinophils were infiltrating all the layers of the bowel wall. Discussion. Eosinophilic gastroenteritis can affect any part of the GI segment. Small intestine and stomach are the most predominant areas. Klein suggested a classification based on the histology of the lesion, being mucosal, muscularis, and subserosal disease. The activated eosinophils induce inflammatory response by secreting a variety of mediators that lead to structural damage in the infiltrated intestinal layers. The uncommon presentation of eosinophilic gastroenteritis includes an acute abdomen, a colonic obstruction, eosinophilic ascites, and bowel perforations. The diagnosis of eosinophilic gastroenteritis is problematic because the final diagnosis requires histological confirmation. Here we conclude that though rare, a dual perforation is not the first thing a surgeon may be thinking while conducting a laparotomy, but nonetheless, he should be ready for any surprise the acute abdomen may spring. Hence, for being a successful surgeon, both knowledge and alertness still remains the key. Here are my references. Thank you.
Yeah, questions from Rajshekar sir?
Diagnostic laparoscopy was better if it had been done prior to the surgery.
So
Because you
why
were
can't it be a diagnostic laparoscopy instead of laparotomy? Because you,
Sir, because there was rigid abdomen present in.
okay, okay.
Sir, there was a rigid abdomen present, sir. So, and plus, sir, in the initial CCT reports as well as in the initial clinical examination, it was provisionally diagnosed to be an acute appendicitis.
So if it's a ileal perforation, the X-ray would have been shown the gas under diaphragm.
Sir, unfortunately, sir, the X-ray did not show any gas under the diaphragm. Neither the CCT abdomen and pelvis showed any gas under the diaphragm or any other signs of ileal perforation, which made it very confusing for us to even suspect that there is any bowel perforation.
No, what made you
Perforation does not show gas in the diaphragm.
Okay, accepted this answer. And still the diagnostic laparoscopy, whatever may be the abdomen, acute abdomen, now the diagnostic laparoscopy is one of the diagnostic modality for an emergency. This
Yes.
what we are.
Yes, sir.
Yeah.
Correct.
And what made you, do another laparotomy? You could have done a laparotomy straight away, or what made you, because you already found a bad appendix, what made you think that there may be another pathology? Because the
Sir,
CT did not suggest it.
Sir, as soon as we opened the peritoneum, sir, there was fecal contaminated fluid noted in the peritoneal cavity, sir.
Yeah.
So, which made us think that probably there is some other pathology. And just to be on the safer side, we thought we should extend the incision and explore the bowel proximally, sir.
So you didn't do a different laparotomy, you just extended the incision.
No, sir, it was a McBurney's incision, sir. We placed
Yeah.
a new incision of lower midline incision, sir.
Possibly, I think if a diagnostic laparoscopy had been done, you could have avoided 2 incisions.
Yes,
If at all you needed a laparotomy, you could have done 1.
yes, sir. Correct, sir.
Yeah.
Sir,
And there
actually,
could have-
sir, it was done in an emergency.
No, see, emergency also, diagnostic laparoscopy is an emergency procedure. It
Sometimes
is not.
in a medical
Yeah.
HL, we don't have a facility to do the diagnostic in an emergency.
Laparoscopy is not
Laparoscopy is not
available.
available in the duty. That's why they have done it laparoscopy.
No,
Yes,
see, I agree with that, but but still, doing 2 laparotomies is probably, that is why if you had suspicion, you could have gone for 1 lower midline laparotomy that would have saved patient 2 incisions.
so initial suspicion is an acute appendicitis.
Can you not look at the ileum through the appendicitis incision? You can.
Yes, sir. We can, sir.
Yeah.
Uh,
I cannot understand the rationale of doing a further laparotomy. You could have extended the incision.
yes, sir.
Whoever has done this, can they explain what was the logic behind doing a second laparotomy?
Yes, sir. Anyway, the time's up. I think we'll move on to the next paper, next poster. Please call up.
Thank you, sir.
Thank you.
It's the wrong message.
Right. Next.
Good evening, everyone. Today I'll be presenting a poster on a rare case of pararectal cyst. Introduction. Cyst tumors arise from the interstitial cells of Kajal and their mesenchymal in origin. Rectal and pararectal cysts constitute 5% of all cysts. The incidence of pararectal cysts is 0.45 in 1 million cases. True cut biopsy, CECT, MRI, and FDG PET remain the mainstay for radiological evaluation. Here is a rare case of pararectal cyst abutting the mid-rectum laterally, to which the patient underwent APR resection with colostomy is reported. Case capsule. A 24-year-old male patient presented with history of progressive constipation since 2 months with significant lower abdominal pain since 15 days. There is no history of bleeding PR, mass PR, weight loss, or loss of appetite. Per abdomen findings were normal. Per rectal findings were suggestive of a large bulge felt involving the entire rectum from left lateral aspect, suggestive of extrinsic mass compressing the rectum. Sphincter tonus normal. The provisional clinical diagnosis was query pararectal tumor. Coming on to the investigations, USG abdomen and pelvis, CCT abdomen and pelvis, MRI was suggestive of a large mass lesion in the pelvis adjacent to the rectum, abutting the rectum by left lateral space. Colonoscopy was suggestive of extrinsic compression over lower rectum causing luminal narrowing. The true cut biopsy HP was suggestive of pararectal lesion likely to be cyst. FTG PET CT scan was suggestive of large mass in the pararectal region measuring 9.8 into 7.6 into 10.1 centimeter. An enlarged left obturator lymph node likely to be metastatic was noted. A few smaller left anterior external iliac and common iliac lymph nodes were noted. Surgical procedure was done was laparoscopic assisted APR with left-sided colostomy. The intraoperative findings were large tumor cyst involving mid-lower rectum bulging to left levator muscles. It was densely adherent to prostate and seminal vesicles. The satellite lesions present were part of main tumor infiltrating left obturator foramen. There's an extensive vascular supply from left pudendal artery and internal iliac artery. HPE was suggestive of cysts with spindle cell features and storiform or whirling pattern. IHC was suggestive of Vimentin positive and DOG1 positive cyst. Discussion. Pararectal cysts constitute less than 5% of all cysts and 0.1% of all colorectal cancers. The management and prognosis of cysts have improved due to advanced diagnostic tools and the role of IM. In this case, the patient defaulted initial 3 months course of IM therapy, hence debulking of tumor is not appreciated. The tumor size had progressed to around 10 into 10 centimeter by then, which became the absolute indication for surgery, that is APR. Also, this case remarks to be rarer as local lymph node metastasis is unusual in cysts unless it is a STH deficient cyst, which is commonly present in the pediatric age group. Unlike in this case, there is an adult presentation, making it a rare presentation. Conclusion. Cysts of rectum and pararectal space are rare entities reported. The preoperative IM treatment results in substantial tumor shrinkage and facilitates function preserving surgery. Also, rectal cysts have a high risk for colorectal for local relapse. Hence, postoperative IM should be systematically considered, which has shown desired results in this case with recurrence-free year. These are my references. Thank you.
Yeah, questions from the judge?
Was it involved in the anal canal too, or only it is confined to the rectum?
Sir, upon colonoscopy, it was confirmed that the mass was compressing the rectum externally, sir. It was an extrinsic mass.
I know,
and,
I know.
What level?
Could
The lower rectum.
lower. Could the anal canal, could it have been saved? And could a colostomy have been avoided? That's what is my question.
For that, how many centimeters from the anal?
How far was it? The lower end of the tumor was how far
Sir,
from the anal verge?
Sir, AR was possible. Why you have done the APR, sir? Is asking.
No, I am asking, was it possible? Just explain.
Sir, the strategic location of the tumor, that is lower rectum, compressing lower rectum, and size of the tumor was around 10 centimeter, which is an absolute indication for APR, sir. And functional preserving surgeries can't be done in such cases.
No, see, it was not involved in the anal canal. still a very ultra low anti-resection done could have been attempted by a good surgeon, an onco-surgeon and all. I am just asking everybody here.
So we have
Could it have been
Dr. Venkatachala. So can you?
Yeah, somebody
No.
like Dr. Venkatachala.
No, it is thinking possibility. No, so actually recurrent free should be there. If you want to
Yeah.
preserve the function of the sphincter, so if
Yeah.
you're compromising the resection, the artery resection,
Yes.
that's why they have prepared a APR.
Yeah, fine.
At least 1 centimeter at least margin, because this tumor arises from the muscle coat. There must be a margin. If you don't get that much margin,
Yeah,
then
that's
below
true.
that, it's difficult. Okay. Second is the lymph nodes, they're generally not involved in gastrointestinal stromal tumors because it is a sarcoma. So mostly we don't do it unless there is a clinical evidence of suspicion. We don't generally touch the lymph nodes. Whatever comes in the mesorectum, that will be analyzed.
Any
Since
other?
it was R0 and R1 grade, just said we couldn't do a functional preserving surgery. And since size was 10 centimeter and the mitotics index noted was around more than 5 per high power field, we had to do an APR, sir.
Okay.
Any other questions? Okay.
The true cut biopsy was done through rectum, per rectum.
No, sir. Abdominal.
Through abdomen.
Yes.
CT guided.
Thank you, sir. Thank you, doctor.
I request now Dr. Shefali Shetty to present the next poster.
Good evening. Today I'll be presenting a unique case of an anterior abdominal wall sinus tract bridge to the ovary. Abdominal wall sinuses are infrequent. Deep pelvic infections, tuberculosis, retained foreign bodies such as suture material can lead to sinus formations. The incidence of multiple surgeries as focus of infection and leading to sinus tract formations are exceedingly rare. Only 3 cases of sinus tracts post LSCS have been reported previously. Here we outline a rare case of an anterior abdominal wall sinus tract abutting the right ovary. Case capsule: a 55-year-old female with P3L2A1 status came with complaints of recurrent discharging sinus on the lower abdomen since 27 years, pain abdomen since 11 months, no symptoms suggestive of tuberculosis or history of contact with patient of tuberculosis. The patient underwent bilateral abdominal tubectomy 27 years ago during the last LSCS, which was done for an IUF. Per abdomen findings showed a discharging sinus of 0.5 by 0.5 centimeters, noted 4 centimeters in the infraumbilical region along the previous LSCS scar. A provisional diagnosis of infraumbilical sinus tract post LSCS and tubectomy and post tuberculosis was made. Investigations: blood parameters and chest X-ray were normal. Discharge culture and AFB were negative. Sputum AFB Montague's test were negative. Ultrasound of the abdomen pelvis showed a sinus tract measuring 3 by 2 by 1.5 centimeter with intraperitoneal extension. MRI abdomen pelvis showed a sinus tract of 2 centimeters extending from the skin surface into peritoneal cavity with the blind end of the tract abutting the right ovary. Surgery performed was an infraumbilical sinus tract exploration and excision of the tract with right salpingo-oophorectomy. Intraoperatively, the tract was 3 centimeters in depth and it was adhered to the right ovary and could not be skeletonized separately. Histopathology report showed features consistent with sinus tract. The tract was covered by stratified squamous epithelium. Right ovary showed no cystic follicles and right fallopian tube was unremarkable. And it showed no granulomas, atypia, malignancy, and endometriosis. In India, keeping in mind the prevalence of secondary tuberculosis, based on history, investigations, and histopath, a diagnosis of tuberculosis was ruled out. Sinus tracts can develop from repeated surgeries due to increased chances of infection and risk of injury to pelvic organs. A case report from 2018 of sinus tract arising post LSCS due to retained suture material in the rectal sheath has been reported. In our case, there was no evidence of retained suture material, unlike the previously reported case. Here, it was inferred that an absorbable suture material was likely used for the tubectomy, leading to formation of granulation tissue around the tubectomy site and development of the tract. In conclusion, a diagnosis of post-surgical sinus tract formations in the abdomen should be borne in mind and evaluated for. Such non-healing sinus tracts, if not evaluated thoroughly, can lead to persistent infections due to incomplete excisions. A complete understanding and assessment of wound etiology and complete extraction of tract is pivotal to ensure satisfactory recovery. Here are my references. Thank you.
Questions from the judge?
Nothing much. It's a straightforward case. Yes.
Yeah. Any questions from the judge, sir? Okay.
No
I
questions.
have a question. Was this really LSCS section or a vertical this thing? Because earlier the cesarean section incisions were different. Was this a lower segment cesarean
Yes.
section or something else?
This was a lower segment section.
Then you should have a
Lower-
panel steel incision, right?
No,
It's
so,
not suprapubic.
so she's had 3 LSCS before, and all the 3 were
The
on the
vertical
same line.
incision.
Vertical.
So there is earlier we used to call as higher segment cesarean section. Lower segment is they open through the cervix. That is the lower segment. You're trying to. So they may have done it through that way. And did you see any suture on the other side or any fallopian rings on the other side? Left
No,
side?
sir. No, sir. There was
Probably
no
they had
evidence.
used suture material which has caused this reaction.
Still, to rule out the tuberculosis, what are the tests you have done? The sample test.
So,
AFB culture you have done, and
yes, sir. We did a FB of the discharge that was there,
Okay.
and we've done a Montoux test.
okay, which is the gold standard test nowadays to detect the tuberculosis?
So CB NAT and quantity.
CBNet, did you done this for this?
No, sir. We sent it for histopath directly, sir, and on histopath that the sample showed no.
No,
sinus
still
lesion.
the CBNet is a very important diagnostic tool to diagnose the tuberculosis. Why? My question. Even if histopathology shows that there is a granulomas and classical features of tuberculosis, before starting the AKT4, we have to get the CBNet. Why? That's my question.
So it has higher sensitivity, but in our case, the histopathology was the only way of ruling out tuberculosis at that point.
Oh.
We had to send the entire sample for.
So this gives a diagnosis as well as the drug sensitivity and whether it is a rifampicin resistant or not. So that's why the CBNet is the mandatory test to diagnose the tuberculosis. Have we done in this patient?
No, so we've not done.
Okay. How will you send the sample of CBNet?
Fresh tissue.
Oh.
We send it in falcon tubes, so 2 falcon tubes.
No, what will you mix? Formalin or normal saline?
Normal saline.
Yes, normal saline. Any other questions? Okay, we'll move on to the next. Yes. I think we are done with the poster. No,
This is last poster.
Good evening, everyone. I am presenting a rare case of enterocutaneous fistula following mesh erosion post laparoscopic ventral hernia repair. Introduction. Enterocutaneous fistula is an abnormal communication between the mucosal epithelium of the intestine and the skin surface. Incidence of enterocutaneous fistula post-mesh repair is 3 to 3.5%. It is a challenging problem due to its high mortality of 39%. Case capsule. A 56-year-old female, a known case of type 2 diabetes mellitus and hypertension, presented with complaints of discharge from the previous surgical wound after 6 months from the post-operative period. Previous surgical history, she underwent LSES 30 years ago. She also underwent repeated surgeries for hysterectomy and recurrent ventral umbilical hernia 4 times in the past 10 years. Laparoscopic ventral hernia repair in October 2020. On examination, her vital signs were normal. For abdomen findings, feculent discharging wound 4 into 3 centimeters noted on the lower part of the midline surgical scar. Provisional clinical diagnosis was enterocutaneous fistula. Following laparoscopic ventral hernia repair, the causes was to be ruled out. Investigations. Blood investigations were within normal limits. USG abdomen pelvis, distal ileal adhesions to anterior abdominal wall, and fistulous tract couldn't be visualized on USG. CECT abdomen and pelvis, enterocutaneous fistula communicating with distal ileum. Defect is noted between rectus abdominis muscle. Surgery performed was exploratory laparotomy. Intraoperative findings. Abdomen was opened, prolin mesh was removed with multiple non-absorbable tackers, which was adherent to anterior abdominal wall. Resection of the bowel was done proximal to the opening of the ileum and up to the ascending colon. End-to-end anastomosis was done. Post-operative and follow-up period was uneventful. Histopathology report. HPE features are consistent with enterocutaneous fistula with acute and chronic inflammation. Lymph nodes identified showed reactive morphology, no evidence of atypia or malignancy. Discussion. As in this case, enterocutaneous fistula after hernia repair can occur due to multiple factors, including mesh migration and erosion into adjacent structures, including the bowel. In the present case, the patient did not have any symptoms of intestinal obstruction. The resultant fistula was well localized as it involved a very small part of the circumference of the bowel. Conclusion. Enterocutaneous fistula is a rare and late complication of prosthetic mesh repair of ventral hernia due to chronic erosion of bowel by mesh. The incidence of multiple ventral hernia repairs leading to tissue ischemia and formation of enterocutaneous fistula is extremely rare. These are my references.
Questions from the judge?
What was the mesh used?
Sir,
And, it
polypropylene
was
mesh.
Rolling.
Yes, sir. Prolin mesh.
Polypropylene. Okay.
Yes, sir.
Regular prolin.
Regular prolin
Okay.
mesh.
And what was the time gap between the laparoscopic mesh repair and the enterocutaneous fistula?
6 months, sir.
Till 6 months, patient was fine. Wound had completely closed, no evidence of any fistulas till 6 months.
Yes, sir.
What are the clinical features in 6 months? Whether the patient was all right for 6 months or a recurrent
Sir,
abdominal pain or any discharge in last 6
Sir,
months?
laparoscopic ventral hernia repair was done outside.
Okay.
So she had this complaint. She had this complaint 6 months. She's been showing it in outside hospital.
Okay.
So they were managing her conservatively. So.
Since 6 months, they are managing conservatively. After post-operative, how many days she started developing the
So
symptoms?
after 1 month. Sir.
1 week of the post-surgery. Sir, 1 week of the post-surgery.
Okay.
So, do you think can we use the regular prolin mesh for the laparoscopic ventral hernia repair?
Yes, sir. We can use.
Okay.
Dual mesh also we can use.
Any comments on the usage of the mesh, sir? Regular mesh or dual mesh?
From the experts.
What Durgana sir says?
No, it is controversial. So when it comes to the litigation, definitely there is objection for the prolin mesh.
Yes, sir.
Harish. Harish.
Yes, sir. Yes, sir. Please, sir.
This debate has been closed
Yes,
because they have moved on to doing other repairs now. So there is no evidence that enough meta-analysis shows that even Indian studies, which is actually published by Dr. Lakshman, and also international studies show that the type of mesh has no bearing on production of enterocutaneous fistula. And I think there is enough evidence to say that if a judge asks this question, if one of our experts say that there is no difference between the two fistulas, there will be no legal issues also. I think it is the companies which are making it a legal issue to promote their mesh. That is all.
Yes, sir. It's a always debatable issue, and I
It is
asked,
not, no debate. No debate. It has been settled. That is why now you are doing all the other repairs like the anterior compartment, posterior compartment. All these things have come because the debate about what mesh to use, the dual mesh, all these things have all been settled.
okay.
So intraperitoneal mesh itself is controversial, or
No, so intraperitoneal mesh, it's 95 to 98% of them will not have any problems, sir.
Okay, sir. So
Only 2 to 3%.
In the legal issues, if the court says you are not, why did you use this mesh?
No, there is no legal. That is what the court will not say it. It is our own medical fraternity who will say it. So all of us should actually know the facts before we go and talk nonsense in the court, because there is no evidence that a proline mesh is any worse compared to the dual mesh. I have seen anecdotal reports of dual mesh causing more complications than proline mesh.
Okay.
So, but there is no, if you look at the literature, whether it is Indian or international, there is no difference.
Okay, sir.
So our expert witnesses, when they are called in the court, should mention this. If we give it up, then only the courts will go against the surgeon. Otherwise, the judge will not know.
Yeah. So what are the other causes for?
Ravi Shankar, 1 second.
Yeah.
See, is there any papers to suggest which mesh can cause more erosion, like either a proline or the dual mesh? Like
No, actually, you look at Dr. Lakshman has produced a meta-analysis which has come up about 5-6 years ago. It shows that the complication rates are similar. In fact, complication rates are higher with the dual mesh, but they don't attain statistical significance. So that is why, and there are international papers also. And if you look at the 2020, the Hernia Society recommendations, they don't recommend that you should use a dual mesh or this one. Proline mesh is good enough. So these are International Hernia Society, recommendations based on consensus conference. So I don't think there is any debate. So please, all of you, don't keep on bringing up this legal issue. There is no legal issue.
okay, thank you.
But still, I am not dare enough to use the regular mesh for all my cases, sir. At least 8 cases per month I'll do. But still, I am not dare enough to face this.
Harish wants to know, will he be penalized by using dual mesh?
No.
I cannot. Thank you, sir.
You can be penalized for using dual mesh, Harish.
I don't do that. So thank you, doctor. Move on to the next.
Apart from the mesh itself, there are so many other risk factors are there.
Of course.
In this case, actually, multiple recurrent surgery.
Correct. That is the problem. That is, I don't think mesh was the issue. Multiple surgeries is the issue in this case. I agree totally with you, Dr. Durgana.
Ravi Shankar, this is Dr.
Yeah.
Here. Can you quote me one journal which has said proline is as equivalent as dual mesh, or it is superior to them? I don't want this meta-analysis. I want to know which journal has come out with saying that proline is superior or equivalent to dual mesh. So no need to use dual mesh.
Sir, you cannot quote one article. There are multiple articles, but the main thing is the International Consensus Conference of the Hernia Societies that has actually conclusively said that meshes, any mesh you use does not actually matter as far as the fistulation or intestinal obstruction or other complications related to it.
What happens?
So this is actually, I will send you the link to that. It is a 200-page document, so you can look at it.
And one thing, the medical council and the court look into textbooks more than journals or.
No, not necessarily. It is how you actually present. If you present the data that is available, published data, they will accept it. It is only if a vested interest which actually perpetuate this problem. Here, show me one person who has been convicted for using proline mesh. I don't think there is anybody.
Yes, sir. Thank you, sir.
Okay.
Doctor, we'll move on to the paper.
Thank you very much, sir.
Ravi, somebody must see the chat box questions and ask the questions, because we don't have the privilege. The laptop is.
I request Dr. Ravi Shankar sir to do that, sir, for us. Any questions in the chat box, sir?
No questions in chat box.
Thank you, sir. Good debate on the mesh again. So thank you, sir.
Thank you.